gynecological resident rotating in a large private hospital, I had come to detest telephone calls because invariably I would be up for several hours and not feel good the next day. However, duty called, so I answered the phone. A nurse informed me that a patient was having a difficult time getting rest, so could I please see her? She was in the gynecological unit, not my usual duty station. As I trudged along, bumping sleepily against walls and corners and not believing I was up again, I tried to imagine what I might find at the end of my walk. Maybe an elderly woman with an anxiety reaction, or perhaps something particularly horrible. I grabbed the chart from the nurse's station on my way to the patient's room, and the nurse gave me some hurried details. A 20-year-old girl named Debbie was dying of ovarian cancer. She was having unrelenting vomiting, apparently as the result of an alcohol drip administered for sedation. I thought, very sad. As I approached the room, I could hear loud, labored breathing. I entered and saw an emaciated, dark-haired woman who appeared much older than 20. She was receiving nasal oxygen, had an IV, and was sitting in bed suffering from what was obviously severe air hunger. The chart noted her weight at 80 pounds. A second woman, also dark-haired but of middle age, stood at her right, holding her hand. Both looked up as I entered. The room seemed filled with the patient's desperate effort to survive. Her eyes were hollow, and she had suprastral and intercostal reactions with her rapid inspirations. She had not eaten or slept in 2 days. She had not responded to chemotherapy and was being given supportive care only. It was a gallows scene, a cruel mockery of her youth and unfulfilled potential. Her only words to me were, "Let's get this over with." I retreated with my thoughts to the nurse's station. The patient was tired and needed rest. I could not give her health, but I could give her rest. I asked the nurse to draw 20 milligrams of morphine sulfate into a syringe. Enough, I thought, to do the job. I took the syringe into the room and told the two women I was going to give Debbie something that would let her rest and to say goodbye. Debbie looked at the syringe, then laid her head on the pillow with her eyes open, watching what was left of the world. I injected the morphine intravenously and watched to see if my calculations on its effects would be correct. Within seconds, her breathing slowed to a normal rate, her eyes closed, and her features softened as she seemed restful at last. The older woman stroked the hair of the now sleeping patient. I waited for the inevitable next effect of depressing the respiratory drive. With clock-like certainty, within 4 minutes, the breathing rate slowed even more, then became irregular, then ceased. The dark-haired woman stood erect and seemed relieved. "It's over, Debbie." Now, my first question to you is, what jumps out at you? Yeah, Tom.
The fact that she went from not knowing Debbie and looking at her chart to killing her, I mean, hoping her to die within, minutes.
Okay.
Never even talked, no, we didn't find out if, was it really the Kool-Aid or was it just, frustration and anger at the current moment?
I
Okay.
was surprised there wasn't dialogue about what he was about to do.
Okay.
I was kind of surprised the nurse didn't question the doctor regarding the 20 milligrams, that she would have known that that would have done what it did.
Okay. Any other things that jump out at you?
That the doctor was sleepy, groggy, not really with it.
Okay.
Bumping into walls.
The other woman, the second woman, is sounding like mom.
Okay.
was not necessarily happy, but relieved that the thing was gone. I mean, it's not so much that she was relieved, just that she just let it happen without saying anything.
Okay. Marilyn?
And that he was a resident and didn't make any calls to perhaps the doctor that had been treating her?
Okay. Okay. Ethically, what sticks out as you hear this, read this case and heard this case? And you have a cheat sheet right there in front of you, so you can cheat your little hearts out trying to remember what ethical issues might be at stake.
Did the resident, was the resident able to determine autonomy? I mean, was the woman fully autonomous, or was she just, she had an alcohol drink? Was she making a decision under the guidance of drugs?
Okay. What did she actually have autonomy? Remember, one of the things that we said about autonomy was that you had to be capable of making an informed decision.
He didn't give her any autonomy at all. She wasn't informed at all.
Boy, that came back pretty quick over there. Marilyn.
But did she have a healthcare proxy?
Well, the only facts that we have are in front of us. And one, in that sense, if we make assumptions, okay, they can take us down very different rabbit holes. And I don't say that pejoratively. So let's just deal with the facts that are in front of us. But that is an important fact.
So now it says the nurse gave some hard details. Hard details. So it's, yeah.
But still, the doctor can't kill anybody.
Okay. Which principle would that violate?
All of them.
You were listening. It would. I mean, we're laughing, but autonomy was not upheld. The doctor may have believed that he or she was being a benefit to the patient, but there's no way of the doctor being sure that the doctor was.
The only benefit he gave her or her surviving family was less medical bills. That's the only benefit.
And ethically, would we say that's a benefit?
No.
Janet.
Let's get this over with. The patient said that.
Okay. What might that mean?
Might mean that
Okay, Tom?
it could be as benign as fix my current problem, not, kill me.
Right.
Let's get this interaction over. She's tired of seeing doctors. Very vague.
Precisely. Precisely.
And
Yeah, go ahead.
the call that came in, all it says is that the patient was having difficulty getting rest. Could I please see her?
Right. And the hurry details are just that she's a 20-year-old girl dying of cancer, and she was having problems with vomit because of her current medication. Doesn't that warrant a change of medication?
Or anti-vomiting meds or something like that.
Okay. What would, in this scenario, remembering last week's discussion, using your cheat sheet, do you think that the doctor was responding from a sanctity of life position or a quality of life position? And why do you think quality?
Because here's this 20-year-old girl who can't stand, can't breathe on her own, can't do anything for herself, and is suffering terribly.
Right. And remember last week when we were talking about sanctity of life, one of the things that we were saying is life is of infinite value.
I'm not sure everyone understands that this 20-year-old was drowning.
Okay.
That she felt like she was drowning, and there was no helping her. I mean, that's clear.
Her lungs were filling.
Her lungs were filling, and she was suffering from air hunger, and the supraesternal and intercostal reactions are basically
Water.
your chest is, you can actually see the rift because the muscles between them are contracted inward as opposed to outward because there's not enough air pressure.
You can do drainage tubes too.
But if she's on supportive care, then she wouldn't come back.
Ah, now we come to another key word in here, supportive care.
Can the lung be drained at that point? But it's still supportive care, you're sort of giving up. Well, aggressive intervention, because you're just trying to keep the person comfortable.
Yes, Michael.
Yeah, when I heard you read the story, I didn't have it in front of me, it wasn't very clear as far as the dose of morphine chosen. What was the intent? Was the intent?
The respiration.
Was the intent to bring about death, or was it?
Yes.
Yeah, it's not clear if that was actually the intent or if that was.
Well, now,
Mary?
go ahead, Christine.
I didn't understand what the terms were, those big medical terms.
Yeah, don't worry about them.
Bigger, smaller one. With that further information, maybe the dose on a person who didn't have lungs full would have just caused rest. But maybe because her lungs were full, that rest allowed her to do
Yeah, but this information was
other
given to the
stuff.
doctor.
In the case, it says with qualified certainty, so
So it
he was
sounds,
expecting.
so it sounds, but it does sound
The
like.
doctor's expecting.
Tom.
Well, it says enough, I thought, to do the job, and you know ultimately what the job was, so she thought.
Well, and then later she says, I waited for the inevitable net effect
Right.
of compressing the respiratory drive with clockwork certainty, blah, 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 blah.
Okay,
She got it.
so, yeah, so
The doctor was expecting that.
Remember, I made the comment last week, I talked about how when somebody is in terminal pain and on a morphine drip, and they need to balance the amount of morphine vis-a-vis their weight, their respirations, their heartbeat, so that you don't give so much that you depress respirations and heartbeat such that the heart and the lungs don't work. I had a parishioner in this class who was talking to me this week and was talking about a scenario, not terminal, but a relative who was in great pain, and the parishioner asked the medical staff if the morphine couldn't be increased in order to make their relative more comfortable. And the response was, no, we can't do that. And what the parishioner and I got talking about was the medical staff did not lie. They just didn't give
the rest of the
all of the information that would have been helpful to the family to be able to say, okay, no, we don't want to put the relative over the top, okay? We're trying to reduce the pain, okay? We can't give any more. You know, families can become more supportive of somebody who's in great pain when they understand that there isn't any more morphine that can be given at that point in time. Ben?
I don't know if we're remembering that the doctor said, I was going to give Debbie something that would let her rest and to say goodbye. So the other woman in the room knew.
Because she would have been...
Supportive care only, she's suffering.
Right.
The doctor, you know, in the context of the moment, there's no ambiguity in my opinion.
Dick?
Well, following up on that, there's an implication in here. First of all, Debbie said, let's get this over with. Like she understood what was about to happen, and the dark-haired woman was actually relieved. The implication being there had been prior discussion about end of life, what should we do? type of thing.
One of the concerns in a case like this is you may be absolutely correct, but the beginning of this case makes it clear that that discussion was not with this particular doctor. And this particular case doesn't give any indication that that information was relayed to this resident coming in the middle of the night, groggy, dead tired, not his or her patient. In they come to make decisions. You're absolutely right. There could have been that discussion. In the absence of any data suggesting that that kind of a discussion has happened, did the doctor, from an ethical point of view, do the right thing? And you can't just tell me yes or no, you have to say why.
Well, I said originally, I was sure there was no discussion before he gave it the morphine.
Tom?
I agree with Bob and Dick. I think it was clear what was happening. The three people in the room knew that the patient was going to die. But I don't think that there was adequate sort of history, discussion, thought to kill the person, I think that demands more than sort of the let's get it over with comments and, even the, to let her say goodbye, that type of thing. Doesn't seem like enough.
Even if she was autonomous, didn't you say something about people wanting to commit suicide, that we're allowed to strap them up into these white jackets so that they can't?
Well, no, I didn't say that medical staff is allowed to, but if somebody is suicidal, and we don't have any indication here that she is, but if somebody is suicidal, healthcare professionals who want to be a benefit to their patient may believe that what they have to do is put them in restraints to keep them from jumping out of a window. But that, of course, then becomes a violation of autonomy, can be a violation of autonomy, and that brings us back to the prima facie duties of these principles, that they're all prima facie. At first glance, they're all the most important, and then you've got to work your way through which one is going to be the operative one. Hang on, Michael, and then Ben.
So one thing that just jumped out at me is that there didn't seem to be any discussions as far as, was there any other family that needed to be present, or, she wanted present, any clergy that she wanted to be present, and those things that definitely should be taken care of at the end of life decisions are being made.
Good observation. Ben?
Well, to take the devil's advocate, one could argue that he did the right thing if you take the rights approach. All human beings have dignity and they're treated as ends, not means to an end. And if you combine that with a social contract approach, with the social contract in our world today is a fluctuating thing, where 20 years ago, active euthanasia was anathema. We couldn't even think about it. Now, what state was it that just passed a law, or at least it came up, it was out west? Oregon?
No, Oregon has it already. Was it Washington that just added it? Washington, yeah.
So, again, you could argue from the social contract that his actions were ethical.
Yes and no, because the social contract for...
I thought they were right answers.
Everybody else, not you. You were back in 11th grade math class, Buster. I only say yes and no because under physician, no, this is always hard to say fast, physician-assisted suicide, okay? There has to be this period of time in which, at least in Oregon, in which it is established that the patient who is requesting physician-assisted suicide is indeed autonomous, that the complications of whatever they're suffering have not impaired their decision-making capacity, and all of that has to be signed off before the physician can issue the script.
So the social contract is based on legislation?
In the state of Oregon, and I'm guessing, I've not read enough about Washington, but I'm going to guess it's the same.
The social contract theory approach to ethics in general.
I think so.
Yes.
Is it based on legislation?
Right. The social contract, historically, from an ethical point of view, from Hobbes and Locke, was the whole idea behind constitutions. I mean, our Constitution is a social contract, okay? And so it's based on that, and that's what I meant when I said several weeks ago that when you have a social contract, individuals agree to give up some rights for the common good of the community as a whole. And no, I'm not going down that rabbit hole. Never mind. Cheryl.
I'm wondering why there's no thought to make her more comfortable short of killing her at this point. I mean, why, if the morphine at a certain rate can have her rest with regular respirations, why not make her comfortable short of killing her? I mean,
That's the way it should be done in hospitals.
doctor.
I mean, but do we know that, well, he could have been made more comfortable with less morphine.
Sure. Well, it says, yeah, I mean.
I don't know, is that actually the case?
I mean, it's kind of a weird thing, is you can suppress somebody so they're really not living, so they're just like there. You've made them more comfortable. I mean, hospice nurses have this weird sense. It's like, oh, they're uncomfortable, we'll just go a little bit higher, a little bit higher. Eventually they die. So, I mean, whether it's going to be now or in 3 weeks, I mean, but that's the way it is.
There's a big difference between whether it's now and whether it's in 3 weeks.
Yeah, but they, you know, in those 3 weeks, they can be so sedated, they're not going to have any quality of life or interaction with their family, but you haven't given them the dose to kill them. You suppress their respiration so they're sedated and they're comfortable. And that's how hospice works in this state.
All right. I want to get to the other case. So a wrap up on don't turn your pages. I'm going to tell you some important piece of information. You see at the bottom of it, it's over, Debbie. It says, from A Piece of My Mind, a feature in the January 8th, 1988 issue of JAMA. JAMA is the Journal of the American Medical Association. A Piece of My Mind is a column in which physicians can write about those awful family members who drive me crazy, or whatever the case may be. This was indeed written by a resident in a teaching hospital, and it's my understanding from research that the hospital was in Massachusetts, in Boston. And this article appeared, and the state's attorney went to JAMA with a court order to get the name of the physician who wrote this, which JAMA would not release. And apparently they spent, Massachusetts and JAMA spent a fair portion of 1988 in court about this case because the state wanted to charge the doctor with murder. Now, when this happened, the response in the succeeding weekly issues of JAMA from doctors across the country was overwhelmingly against what this particular doctor did. And doctors wrote in and said, we don't do this. You know, that's a violation of this, and we're not supposed to do any harm, and all of this kind of thing. The doctor was never revealed. And so somewhere, I say this not facetiously, somewhere in the world, assuming they're still alive, is the doctor who did this. A few doctors did write in and say, I don't agree with this at all, but I hope that this doctor has a conscience and has learned something, that perhaps the whole writing of all of this has been a way of being able to learn something about how to serve the patients in various situations. So this case is a real case written about in a real medical journal that caused a great deal of consternation 25 years ago. Would it cause the same today? I'm not sure.
Well, if the 911 call's any indication, it probably would.
Yeah, no, you read about the situation out in California where a woman was choking. No, she went into cardiac arrest or something in the dining room, and a nurse was there and refused to do CPR, and refused because she said that the woman would not have wanted it, and the 911 operator was saying, well, there must be somebody in the room who could do it, and the nurse refused to hand over the phone.
It wasn't the policy of her.
It also wasn't the policy, it was against the policy of the nursing home, and the family said that they aren't suing the nurse who was on the phone with the 911 operator because they agreed, their loved one, their mother, grandmother, agreed with the policy. It was an independent living, that's another key point. It was an independent living facility, and the mother agreed with the policy of the facility. She knew what the policy of the facility was, and the family said, we're not suing because they just did what they were supposed to do.
At all for those institutions.
To have that kind of a policy. Right, right. But the 911 operator wanted to say, forget the policy, you have an obligation to do this. All right, the next one. Now I'm going to tell you ahead of time, I'm going to read the next case. There were a lot of comments on the next case, and I didn't give you all the commentary, so I wanted to make sure you would be able to think and talk. Mrs. Jones is an 82-year-old nursing home resident with a long-standing history of heart failure, who is now hospitalized in the cardiac ICU for the third time this year. She is a retired teacher with 4 children and 8 grandchildren. She did not list a religious preference when admitted to the hospital. The attending cardiologist, Dr. Rosenberg, is a heart failure specialist and is an active member of an Orthodox Jewish congregation. On day 3 of her hospitalization, Mrs. Jones developed a fever, which was subsequently determined to be caused by a MRSA line infection from a venous catheter. On day 4, her renal function, kidney function, began steadily deteriorating until her serum potassium reached dangerous levels. She had been unconscious for 2 days, and, according to hospital records and her children, she has no advance directives to guide end-of-life care. Dr. Rosenberg requests a family conference with Mrs. Jones's children, her husband is deceased, to discuss their mother's prognosis and the appropriate next steps in treatment. I'm afraid your mother's health is steadily deteriorating, Dr. Rosenberg tells Mrs. Jones's family. She has a serious infection that has failed to respond to traditional antibiotics. How did she get this infection, doctor? Mrs. Jones's daughter, Jennifer, asks. That's a good question. It's likely the result of an IV line we placed during her admission, Dr. Rosenberg replies. Your mother's infection is caused by a resistant strain of Staphylococcus that is common in intensive care units and hospitals, but we have more aggressive antibiotics we can use. I should also tell you that her kidneys are failing and will need to begin dialysis to ensure that her electrolytes and fluid status are kept at normal levels. Despite this, I think there's a strong possibility she'll pull through. At this point, Mrs. Jones's eldest son, Franklin, interrupts. Look, doctor, he says, my cousin was on dialysis for years, and until he died, he was really miserable. I don't want my mom to have to go through that at this age. I think enough is enough. She has been in the hospital 3 times this year alone. I understand your concern, Dr. Rosenberg said, but you should realize that your mother may not require long-term dialysis. Her kidneys may recover, but at this stage, dialysis is the only solution left to correct her electrolyte imbalances. If we don't lower her potassium, she'll likely develop a fatal arrhythmia. Franklin looks at the rest of the family, who are shaking their heads. Honestly, I think you shouldn't treat her any further. Even if it's not permanent, starting dialysis just isn't a path we want her to start on. And the aggressive antibiotics, I don't see any reason to pour more substances into her already tired body. It's obviously her time to go. Can't you just give her something to make her comfortable? Dr. Rosenberg pauses for a moment and then tells Franklin, we fully intend to keep her comfortable and continue treating her pain. As you know, I am committed to doing what's best for your mother. But in good conscience, I can't stop treating your mother as long as there are reasonable courses of action that I could take to preserve her life. According to the principles that guide my practice of medicine, I cannot withhold life-saving treatment from any patient, especially antibiotic therapy and temporary dialysis, both treatments with uncontroversial efficacy.
Good job, doctor. I'd like to hear from the other kids.
Okay. First question, same as last time. What leaps out at you? Tom.
Jumps out at me first was Franklin talking about his cousin. One experience of the son should not suggest what might happen to his mother. And so the doctor's in a better position to say, what is likely to happen with her.
Okay. Dick.
What jumped out at me was called the family in to consult with them, and then unilaterally decided to ignore their requests.
Okay.
There's no advance directive. Is the big thing.
Right. There is no advance directive. Ben, you had your hand up.
Well, I'm a little disappointed with the article in the sense that it sort of sets up the scenario where we're being told to assume that the physician is approaching his decision from some faith-based issue as opposed to medical. And I mean, it could be that it's faith, he's motivated that way, but there's no obvious in this. I don't see anything obvious in here that says that he was making this decision, or his decisions were being based on his faith.
And he specifically says, according to the principles that guide my practice of medicine, he doesn't say his religious views.
Where do those principles?
Okay.
Those principles to be those principles.
That's beneficence, isn't it?
Right.
Okay, but let's back up. Early on, first paragraph, last sentence, it says that he's an active member of an Orthodox Jewish congregation. Now, the reason I picked this is that last phrase suggests somebody whose faith could have an impact on them as a medical professional, which isn't always that different than if it said that if the name had been Dr. O'Leary and he was a member of St. Joseph's. What I'm getting at is a part of our Judeo-Christian heritage is some level of sanctity of life. It is true that in Orthodox Judaism, as in a Roman Catholic healthcare system, that sanctity of life gets pushed to the highest pinnacle. But there is that one phrase about being a member of an Orthodox. It didn't say Reformed. If it had said Reformed, whole nother ball game. But the fact that he was a member of an Orthodox Jewish congregation says that this is somebody for whom the Old Testament undergirds a lot of who he, well, in this case, I'm saying he, I shouldn't do that, who he or she is. Michael.
So it's not clear to me, since there was no advance directive and there was no ability to discern autonomy independently from the patient herself where that, that authority to make the call lies.
This is where so many of us find ourselves with our loved ones. When there is not an advance directive spelling out what you and I want or what our loved ones want, doctors and other healthcare professionals will call family members in for a consultation. And when that consultation happens, family members will be presented with what are the possibilities. In this case, Dr. Rosenberg is presenting, from a sanctity of life position, is presenting the option that this is not necessarily the end for dear old mom. It's a tough road to hoe. Don't make any bones about it. But this is not necessarily the end. And if it's not the end, then he's going with sanctity of life. In other words, this life needs to be supported. And here's the ways in which we can do that. Stacy first, and then back to Ben, and then Cheryl.
If it wasn't from a sanctity of life point of view, and it was just from an ethics point of view, never mind. I lost track of what you said.
No. I want to stay with that, because if, let's just say...
Because she'd already been in the hospital 3 times. If she wanted to end her life, which her family thinks that maybe she's too tired to go on, for me, if I was in the hospital and I was old and I wanted to die, I'm assuming that I would put something into my will or something that says, this enough is enough. So why is the family, maybe the doctor is just saying, maybe enough isn't enough. This might work. She might, I don't know if I necessarily see it as sanctity of life.
Ben?
I'm still saying, take the sanctity of life off the table.
Okay.
Okay, and stick completely with healthcare principles. He acted within the healthcare, he was obligated to act, given all the other things we know, to act under these principles, and he did. And he did.
Cheryl?
I agree, it's following the Hippocratic Oath, it needs to be what?
Do no harm.
Yeah.
And among the principles, where Stacy was starting, he's trying to be a benefit.
And I think that's what Stacy was trying to say.
Right. He's trying to be a benefit to his patient, okay? And being a benefit to an 82, let's say it a different way. A healthcare professional, to be a professional, better be a benefit to an 82-year-old as much as they would be a benefit to a 22-year-old or to a 2-day-old. Because otherwise, there's a little bit of a problem.
If she had
an advance directive.
And then the doctor said, but I'm still going to fight to save her life. Now we can say, well, you're basing your decision on sanctity of life issues.
Okay. Tina.
Given that this is a 3rd time in the same hospital with the same sort of condition, you would have thought that she might probably, if she felt like she couldn't carry on, said something to either a nurse or a doctor, or had to put in her medical record that she didn't want any extraordinary measures taken.
But the doctor is saying that these aren't extraordinary measures. These are stuff that works. And they could help her with me.
Well, she's in ICU.
Well, she's in ICU because of the condition. But you have to understand, somebody her age who presents with this combination of things is not going to be in a private room on the general med floor, because if she were to crash in the middle of the night, or if something changed, they need to be able to respond to her quickly. So she is in ICU. But we just got to be careful. When you hear ICU, it doesn't mean, whoa, we're almost down there and, down for the count. It means it's a place where the intensive treatment that might be necessary to get you stable again can happen without any major problems. So in that sense, I think that's why she's in ICU. Now, having said that, we go back to what Christine and Cheryl were saying a minute ago. As the doctor points out, these are just normal treatment in the midst of this kind of a crisis. And they might, he believes that they will get her back to a place where she'll be able to go home. Okay.
Yeah, it means you have to keep making the same decision over and over again.
Ah!
My dad was 90, he was in regular hospital, not ICU. And he had a no special, whatever you call it.
No advance directive.
No, he had his...
no extraordinary,
Yeah.
right.
So every time they needed to do a procedure on him, it was my job to go take the directive out of his binder and put it in my purse, put the binder back. The doctor did what he had to do, wheeled him back, he was fine, and the directive went back in over and over and over again, because if the directive is there, the doctor felt that whatever he was doing
was extraordinary.
Yeah. But it wasn't extraordinary. It was, even though he was 90, it was just like a routine procedure.
Well, before I go to Tom and then to Cheryl, let me just inject and say, I think that sounds like a bit of paternalism on the doctor's part, that the doctor could not say, this is not an extraordinary measure, but had to go through this whole thing of pulling the directive. What I mean by that is people today who are 90, and when I say today, I don't mean just 2013, I mean over the last 20 or 25 years. If you're 90, it's not like being 90 100 years ago. So anybody who's 90 today could have another 20 years in them with some dialysis, with some stronger antibiotics. You could have another 20 years.
Or at least a good 5 or 6.
Or at least a good 5 or 6. So what I'm leading up to is we, not just us lay people, but the medical world also has got to realize that talking cold turkey, I'm going to up your antibiotics. That is not extraordinary. That is just straightforward health care. That's all. Now, I can't remember who I said. Ben and Cheryl?
No, I didn't.
Cheryl. Tom, Cheryl, Michael.
I might have done the same thing. I'm not suggesting any sort of judgment here, but I'm just curious. The doctor knew that you were taking that directive out?
Oh, yeah.
Okay.
Yeah, he wouldn't do the procedure if the directive was in place.
Yeah.
So in order to get the treatment, you had to take the directive out.
Yeah.
I have to add it to Jewish doctor in a Catholic hospital if that changes.
You were really...
That's kind of like the Episcopal priest who was the head of ethics in a Roman Catholic healthcare system. But we won't go down that rabbit hole.
What you're saying, my comment was how we think about age, because if you change the case to it was a 60-year-old woman with a heart problem who had been hospitalized 3 times, and how does that make you change? And for some, you know, we think, oh, you get to be 80 or 90 or whatever it is, and then you necessarily, you know, why would you want to continue to live? It just...
She has 4 children and 8 grandchildren. Why else wouldn't she want to live?
I mean, it really strikes me that if you think of it, if as a younger person, would you be thinking the same thing? Really not.
It's a good question. Michael.
So, 2 things. Seems like that at some point the family should have been offered some sort of counseling. Because it seems there were definitely some issues that needed to be discussed between them. And I think that would have been a nice thing. The other point, going back to what Kay was talking about, I don't understand how the doctor, knowing that this advance directive exists, and knowing that the terms of that directive were an issue for him, could act ethically, you know, just by its location. How does that necessarily change, you know, what you believe is the right thing to do?
I'm not sure Kay has an answer for that.
Well, my dad was fully conscious and aware of what was going on, so he made the decision over and over and over again. That's different.
So perhaps the directive was there just to remind and reiterate and put into legalese so that the doctor wouldn't get sued or whatever if he didn't do something, because...
But it's one of those scenarios that we're not going to be able to sort out exactly how and why that doctor did what he did vis-a-vis Kay's father. Last thing I just want to say with regard to good old Mrs. Jones is to touch back on Michael's first comment when he said the family needed more counseling. Not every hospital is set up to provide that kind of help to families in situations like this. And what I mean by that is, if a hospital has a functioning ethics committee, that can be a place where families can go and get some help with trying to sort out, should mom have this dialysis, etc. Not all hospitals in this day and age have ethics committees. Certainly, I mean, Roman Catholic hospitals are required to have them, but not all secular hospitals have an ethics committee that meets on a regular basis. They may have one that meets once a quarter or something like that. The other thing is, this is perhaps the kind of scenario in which family members can get some tools so that when they are sitting there and Mrs. Jones is being discussed, your ears might be attuned to what your siblings, your cousins, your whatever are saying with regard to your loved one whose medical situation doesn't have an advance directive and therefore needs some family consult. The questions to ask, but not just of the doctor, to ask of each other. Why are we ready to let mom go at 82? Franklin says, I'm tired of having to go over and drive her to the doctor. Ah, now we've got a whole nother discussion, right? Sorry, I'm sorry, Erica.
Well, just also, the feelings are tricky because not all are functional. and you might have like disagreements within the family of what is the right path to go, and no amount of
exactly why they have ethics committees.
Mm-hmm. And also sometimes the families might have their own, not agenda, but sort of feelings of end of life that is different than the patient themselves. Mm-hmm. So the patient may be saying, I'm ready, my feeling is, I want to, I'm ready for the Lord to take me or whatever. And the family may say, no. Mm-hmm. And there's a lot of family dynamics that are really hard to...
There are, and it's after 10:02, so thank you for participating. Nice discussion. You can keep all of that info.